I'd like to welcome you to this edition of the award-winning PRS Journal Club podcast with your hosts, Drs. Francesco Egro, Nicole Phillips, and Ira Savetsky. Enjoy.
Hi everyone, and welcome to the November 2018 edition of the PRS Journal Club podcast. My name is Francesco Egro, PRS Resident Ambassador from the University of Pittsburgh Medical Center. And as always, I'm joined by my co-resident ambassadors, Ira Savetsky from NYU and Nicole Phillips from the Harvard Plastic Surgery Program. Today we have the great honor of being joined by Dr. Matthew Hanasono as our guest moderator. Dr. Hanasono is a professor and Microsurgery Fellowship Director at the Department of Plastic Surgery at the University of Texas MD Anderson Cancer Center. Thank you so much, Dr. Hanasono, for joining us on this PRS Journal Club podcast.
Thanks for having me, Francesco. It's an honor to be here.
Before we dive into our discussion, I want to remind everyone that this article, along all of the articles that are discussed on our podcast, can be read for free on prsjournal.com. The article we'll be discussing today is by Drs. Momeni from Stanford and Dr. Kanchwala from Penn, and is entitled Hybrid Pre-pectoral Breast Reconstruction, a Surgical Approach that Combines the Benefits of Autologous and Implant-based Reconstruction. I thought it would be an interesting article to discuss because of the increasing role of both free autologous reconstruction and pre-pectoral implant-based reconstruction as independent types of reconstruction. And I think it is a rarity to combine these two techniques in the immediate reconstruction setting, at least in our center. And that is why the authors in the paper aim to evaluate outcomes following the technical evolution of placing implant and flap in the pre-pectoral plane. So the authors conducted a retrospective review of patients who underwent immediate microsurgical breast reconstruction with simultaneous pre-pectoral implant placements, and they reviewed the clinical outcomes and postoperative complications. And in terms of the surgical technique, so what it involves is splitting of the pectoralis major muscle along its fibers at the level of the third rib. And after removal of the costal cartilage, the posterior perichondrium is incised and reflected in a lateral to medial direction, thus exposing the internal mammary vessels, which are used as recipient vessels. The implant pocket is then precisely defined with the use of mesh and say either ADM or polyglactin, which is sutured to the pec muscle and chest wall along these markings. And prior to completing mesh insert, the implant is then inserted, and the flap is then transferred to the chest and microsurgical anastomosis is performed. The authors highlight the importance to ensure that the mesh and the implant is covered by flap tissue to ensure that the risk of mesh and implant exposure is minimized in the setting of mastectomy skin necrosis. So they performed a total of 23 patients with a follow-up of 8.2 months. The mean age was 47 years and the BMI was 26. 30% of patients underwent adjuvant radiotherapy and none were smokers. The most common meshes used were alloderm in 39% of cases and allomax in 35% of cases. And of the 46 free flaps, 40 were MS-strand flaps, 2 were deep flaps, and 2 were PAP flaps. Implant volumes ranged from 150 to 255 cc's, and the most common implant volume was 210 cc's. In terms of postoperative complications, they had mastectomy skin necrosis in 22% of cases, fat necrosis in 13% of cases, and delayed wound healing at the flap donor site in 17% of cases. They also had secondary procedures performed, including fat grafting in 17% of cases and implant exchange with placement of a larger implant in 13% of cases and removal of the monitored skin island in all patients. So I thought this was a very interesting article, very interesting technique that truthfully I had never seen performed here, and I commend the authors for sharing an innovative technique in breast reconstruction. I love the idea of providing adequate, well-vascularized soft tissue reconstruction with a natural breastosis, but with the benefits of implant's desired projection and without the common implant complications such as rippling or animation deformity. Although overall pre-pectoral hybrid breast reconstruction does appear to be a safe procedure, I thought the mastectomy skin necrosis rate was very high, and I wonder if the tension on the skin envelope caused by the flap and the implant is just too much to take. A related concern is the potential risk of pedicle compression which could potentially be caused by the implant. And, honestly, that would be probably the biggest concern for me of implementing this technique in my future practice. Also, I think that a follow-up of 8 months approximately might be too short to provide a definitive answer on outcomes. But nonetheless, I think this paper offers a new option for breast reconstruction, and I certainly look forward to reading a sequel with a larger series and a longer follow-up. Dr. Hanasono, what were your thoughts of this paper and, specifically of combining free flap reconstruction with implant-based reconstruction? And does anyone at MD Anderson combine these two techniques for medium breast reconstruction?
Francesco, I think you hit the nail on the head with what the risks are, namely free flap loss due to pedicle compression from the implant, also the excess or higher degree of tension potentially on the mastectomy skin flaps, both due to a larger volume and as well as possibly due to a higher weight based on the weight of the implant. And then finally, not sure that they specifically looked at this, but implant position. Are you getting the ideal implant positioning? That being said, I would commend Dr. Momeni and Dr. Kanchwala on publishing this multi-institutional case series and showing their 100% success rate with the free flap survival, because certainly I think that has been the concern of doing immediate combined augmentation with autologous flap reconstruction. There's certainly positives to doing what they've done, one being that it's fewer stages in surgery. And I think what they have achieved here is the next step in evolution. We, in the past, had been hesitant to do this combined autologous and implant-based reconstruction because of the fear of free flap loss. But I think that the use of acellular dermal matrix allows more precise positioning, perhaps keeps the implant from putting weight on the pedicle. And the free flap itself provides protection such that you can put it in the pre-pectoral space rather than the subpectoral space, because you have a free flap covering it. And the fact that even with mastectomy skin flap necrosis that they didn't have implant infections attests to that. That being said, I would still worry if you have skin flap necrosis or any type of wound dehiscence of getting implant infection.
And does anyone at MD Anderson, or actually I'll open up the question to the group, does anyone at MD Anderson or NYU or Harvard do this kind of hybrid procedure?
No, I think this is evolutionary in that we have had experience doing immediate augmentation of our free flap patients, but for the reasons I stated, tend to shy away from it. I think this new era of using acellular dermal matrix to kind of suture or secure the implant into a single space where it can't move around is really the game changer in that strategy. I think just for educational purposes, we have to remind the listeners that there are other options. Probably the most common and most obvious option would be, rather than to augment the reconstructed side, is to do a reduction on the contralateral side for symmetry. Probably more common strategy in my hands, if I wanted volume, would be to do a delayed augmentation. My personal experience with this would be to put the delayed augmentation in the subpectoral plane, because I worry about re-elevating that free flap and interrupting the perforator or the pedicle blood supply. And then probably more commonly in recent years, when we needed volume, is this concept of performing stacked flaps, or for unilateral bipedicled flaps, to really get the entire, for instance, bilateral DIEP flaps or bipedicle DIEP flap to a single breast, or if you're doing bilateral, to do DIEPs and transverse upper gracilis or profunda artery perforator, or whatever your secondary flap of choice is. I think those are the other options.
That was great. Thank you so much, Dr. Hanasono, for your insight. And I'm curious to hear Nikki's opinion about this paper, and also if she has ever seen it at Harvard in her program.
Yeah, sure. So I have never seen it at Harvard. That's not to say it has never been done. I certainly couldn't claim that I know every case, but I've never seen it, and I haven't really talked about it with people. And I have to say that honestly, just the concept of it makes me so nervous. And obviously they've had a great success rate with it. And I thought the photos of, it was only one patient, but the photos of the reconstruction they showed, I mean, it was a fantastic reconstruction. It looks really good. So it's certainly something that, I've learned a lot from reading the paper and thinking about this as an option for the future. But we've already sort of raised the points that as I was reading the article, I mean, I just was thinking, like, I just don't know how I would sleep with an implant sitting right next to my anastomosis. Like, it would just make me so nervous. They've obviously sorted that out. And again, as Dr. Hanasono pointed out, perhaps the use of the ADM or other matrices is really, enough to sort of secure the position of the implant and secure the safety of the pedicle. And then, Francesco, you brought up the other point that I was thinking a lot about while reading this paper, which was that the follow-up time was just so short. I thought it was really striking. I mean, the range was 2 to 17 months. I mean, 2 months. I don't know how you can draw many conclusions from that. So I certainly think we're pushing, as we should be, and in journals like PRS, sort of pushing the boundaries of what we do and pushing the field forward and expanding the way that we think about things. But I did wonder, as you had brought up, can we really comment on the safety and efficacy of this procedure with such a short follow-up time? Dr. Hanasono, I guess that's more of a philosophical question for you. How do we balance out, listen, we've got this great procedure, we've had a 100% success rate, we want to get our results out there, versus, looking at, again, long-term outcomes. And certainly, obviously, at 2 months, we could say probably, the flap safety is okay, but we don't really know about our long-term results at that point in time. So I'm curious to hear your thoughts on that question.
I think part of how we advance and how guys like Arash and Sahil push the envelope is that they try something that's not been tried before, that being skilled and experienced surgeons, that they're going to be the first to try it, and then it kind of remains to be seen if other people can replicate the results. And I do think that there's probably a learning curve. I think you have to be comfortable with both your autologous and your implant breast reconstruction skill set. I certainly think it should be emphasized that even the placement of the implant, selection of the implant in such a way that it doesn't interfere with your free flap, and that you feel confident that the positioning of the implant and the size and volume of the implant are going to be satisfactory. Those certainly take a fair degree of skill and experience.
Absolutely. Ira, curious to bring your thoughts in here. What did you think about this paper?
I agree with everything that was said in this discussion. I'm really enjoying it, and I do think it's definitely very thought-provoking, and just as Nikki and Francesco has mentioned, it is nerve-wracking, no question. I don't think this is something that I think that I will pursue early on. It's something that I think someone who has done a lot of these, this is sort of, I guess, the next step. Here at NYU, I have not seen it done, but I've seen, as Dr. Hanasono mentioned, similar to MD Anderson, I've seen stacked flaps, 4 flappers and things like that. So I think people will tend to gravitate towards doing an additional flap, if possible, for volume before perhaps putting an implant in. And I think, certainly there's patients who are very specific and, that they absolutely don't want any foreign material. And a lot of times that's what brings them to choose autologous from the beginning. I guess the authors compare this technique versus doing latissimus in an implant. I was curious to hear, Dr. Hanasono, some of your thoughts about what are we getting out of this more versus doing a latissimus with an implant?
It just underscores the challenge of breast reconstruction in that we have multiple modalities of reconstruction: implant, pedicle plus implant, autologous free flap reconstruction, and all these variations of combining these. And to some extent, the patient's condition, the wound bed, whether they're radiated or not, the size of their breast, their body habitus, their donor sites, all have to be taken into account. And as you just mentioned, their own personal preferences, the biases that the patient brings in. Certainly this would not be the first choice in somebody who is coming to you because they want to avoid implant-based reconstruction for whatever the disadvantages of implant-based reconstruction are. In some ways, you get the worst of both worlds in that you have a foreign body inside of you with additional risks, particularly of infection and rupture. And at the same time, you have the extensive nature of autologous reconstruction and the morbidity of a donor site. So in some ways, you have the worst of both worlds, but at the same time, The technique that they've outlined is really a possibility of giving you extremely good aesthetic results. My personal bias is that if free flap covering an implant, you get a far superior, more natural looking result compared to implant-only reconstruction. And that being said, also, if you simply just do not have the autologous tissue volume, you have a slender waist or minimal adipose tissue, minimal skin laxity, you're never going to get a larger volume that some patients may desire or may need for breast symmetry. So there's certainly, in my mind, a place for this technique.
I think also perhaps patient selection can be also a bit of a challenge, because I feel that a lot of patients come into clinic for a discussion about breast reconstruction options, but a lot of them have done their homework, and a lot will say, no, I definitely don't want to put an implant in my body, or oh no, a free flap sounds too much of a long operation. And so I imagine that getting patients who are willing to undergo both procedures can also be a bit challenging. And also, since I'm from Pittsburgh and we love fat, we think that it's worth gold. I also want to say, autologous fat grafting can also be a good option, in certain patients.
Absolutely. The fat grafting, that's the fourth modality. I guess I didn't mention, but it's certainly in the last decade or so, it's become a very important modality.
The only reason that I mention is because otherwise Dr. Ruben would most likely fire me if I didn't. But, thank you all so much for a truly thrilling discussion. I really enjoyed today's podcast, and I think with that we'll end our discussion of this article. Thank you everyone to our listeners for joining us. If you like this podcast, please feel free to share with your friends and rate us in the iTunes store. Also remember to tune in to the other two articles we will be discussing on this month's podcast. And finally, please join us this month for our monthly journal club on Facebook, where we will be able to interact directly with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not yet done so already, and it is there where our monthly journal club takes place. Once again, Dr. Hanasono, it was a true honor having you on our podcast today. Thank you so much for joining us.
Thank you so much. It's been my pleasure.